Cái tai này, một phía bên trái này nó sẽ rất là ù, nó ong o, mình rửa mặt này thì nó cứ đột dạt ở trong cái mặt mình ấy. Đấy là nó báo hiệu, thì mấy hôm sau là bắt đầu nó có triệu chứng, mà thường là cái triệu chứng của nó xảy ra vào ban đêm. Khi mình đang ngủ là mình bất ngờ mình vì cái gì đấy mình tỉnh giấc thì là bắt đầu nhà cửa tối sầm quay cuồng ấy. Thế là phải đi cấp cứu. Tôi sợ lắm, chỉ cầu cứu bác sĩ thì nhanh nên không chết mất. Mặc dù mình vẫn kêu là cái tai mình nó rất là khó chịu, thế nhưng mà lại không khám về tai, mà chỉ vì mình nói mình tiền đình, chóng mặt quay cuồng, nôn mửa, thế nên là điều trị theo hướng tiền đình, truyền nước rồi thuốc rồi các thứ, là thần kinh như là bổ thần kinh, bổ não. Sau khi mình xuất viện thì là mình lập tức đi lên đây luôn. Bác sĩ chuẩn đoán là bệnh Ménière. Tôi chỉ mong là các bác sĩ ở trên bệnh viện nó đúng bệnh ấy để điều trị sớm. Một là nó không tái phát, mà hai là cái đợt này nó khỏe nhanh trở lại.
Hello everybody, today we will discuss the management of Meniere's disease and how we do it, at least in the Netherlands, because in many countries everybody does it a little bit different, but in the Netherlands we like to work evidence-based, and that's also how we approach Meniere's disease. So first of all, we should of course start with the question, what is Meniere's disease? And currently Meniere's disease is nothing more than just these criteria. It means that you need to have 2 or more spontaneous episodes of vertigo, each lasting 20 minutes to 12 hours. You must have a hearing loss, low to medium frequency, sensory neural of origin documented, and you need to have fluctuating oral symptoms in the affected ear. And I know that many people talk about high drops, etc., but currently you just diagnose Meniere's disease using these criteria. Maybe in the future it will change, but currently this is how you diagnose it. Well, of course, as I said already, high drops is considered part of Meniere's disease, because what you see is that the endolymphatic compartment increases. The question is, however, is it really the cause, or is it something that happens in co-occurrence with Meniere's disease? Because nowadays many people target really the high drops, but maybe the high drops might not be the cause. And that's what we now also see in literature, where previously everybody said Meniere's disease is high drops. We now know that high drops is actually associated with many inner ear disorders. You can even see it with vestibular schwannoma, you can see it with vestibular migraine, and also healthy subjects show some endolymphatic high drops. So high drops is not only equal to Meniere's disease, but people with Meniere's disease, they might show high drops. And here I will show you a nice picture, because if you in the past everybody says high drops is the result of an increased pressure, it means that if you can reduce the pressure, you might also treat Meniere's disease. And that's also how many of us were being taught in the past. But what we see is that everything we tried to attack the high drops in Meniere's disease failed. And I will come back to that later. Diuretics have not been proven, unfortunately. Endolymphatic sac surgery has not been proven. So everything we try to attack the high drops has failed. And you think about 3 guys. You have a small guy, you have a bigger guy, and you have a tall guy. And here nobody would say, okay, the guy in the middle is bigger because he has an increased pressure that made him bigger. No, there we would say, okay, there are just more cells in his body. And that is exactly what we see if we look at Meniere's disease. If we look at Meniere's disease to new literature, we actually see that it's not really the pressure that's causing the high drops, but it might also be that it's more about hyperplastic growth of cells. So it means that maybe attacking the pressure in the inner ear might not be this, how we can solve Meniere's disease. So therefore, this beginning is just to tease you a little bit and to think beyond high drops. High drops is part of Meniere's disease, but only attacking the high drops might not be the best solution to treat Meniere's disease. And if we look, for instance, already at Meniere's disease when it happens bilaterally and unilaterally, what we see is that Meniere's disease is indeed just a cluster of symptoms, and it can have many etiologies. So there's not just one etiology leading to Meniere's disease. We have the classical Meniere's disease or the delayed Meniere's disease. What you can sometimes see, for instance, is that people first have hearing loss and then they get the attacks. They don't need to happen exactly at the same time. You see that it might run in families. You see it in many people with migraine. And also you see it in patients with autoimmune disorders. So currently we are thinking that several different disorders eventually can lead to Meniere's disease. A new research from Antonio Lopez Escames, who's currently based in Australia, shows that genetics seem to be very, very important also in Meniere's disease. But often these genetics can be recessive. So therefore, you will not make the link right away if not the whole family has Meniere's disease. So it means that something is happening on a DNA basis in the inner ear. And if just your inner ear is not built correctly, treating eye drops, for instance, might not be the solution. Maybe we need to target other things, like the genetic code in the future. So this is just a little bit already a critical start to show you that Meniere's disease is actually quite complicated and not as simple as just a cluster of symptoms and, oh, if you treat eye drops, everything will be better. So what should we do with these patients? Well, first of all, we always advise to get all the right diagnosis. And it already starts, of course, with diagnosing Meniere's properly. Well, sometimes you're happy and a patient comes into your office and you just notice the attack of vertigo and you can even see the nystagmus associated to it. If your internet connection is quick enough, you might see the nystagmus. Or really, if you can even put on the video Frenzel goals, you might see the nystagmus that's associated with it. And then, of course, it's easy because you can ask the patient, what do you feel? Do you have oral pressure? Do you have tinnitus? Do you have a hearing loss? And you can even immediately record the hearing. So capturing the symptoms during an attack, that helps you a lot. But unfortunately, what happens with many Meniere's disease patients is that the function fluctuates in time. For instance, if you here look at the y-axis, you see the function and the time. And here, if you have an attack, the function decreases during an attack, but after an attack, it increases again. And then it decreases again during an attack, and it increases again. So the challenge is often that when a patient has an attack and they go to the doctor, the attack already disappeared and everything looks normal again. So when they come to the doctor cannot notice the hearing loss, so they cannot measure it. And that makes, in that case, diagnosing Meniere's disease quite challenging. But you also often see that in time, the symptoms, they decrease, and then often the vestibular function, actually after an attack, will not improve back to its original origin. So eventually, patients also get the problem that the vestibular organ is not working properly anymore. So in that case, patients might in the beginning have attacks, but in the time, when the vestibular function goes down, they might also suffer from the fact that the vestibular function is not working properly anymore. And then these patients actually have two problems. One, the attacks, and second, that in between attacks, the vestibular function doesn't work properly, and they also get into trouble. And to show you, by the way, that function can really fluctuate, here we have a Meniere's disease patient who has Meniere's disease on the right, and you see the caloric test. And on the left, you see the caloric test in 2014, and you see on the right side that there is a reduced function. But when we measured this patient back in 2026, you saw that actually the function increased again. So this fluctuating function is not only something you only see with hearing, but also in the vestibular function. So if you want to get the right diagnosis of Meniere's disease, you should always start with proper history taking. After all, history taking is the most important diagnostic tool. Not all the other things like V&G, etc. No, history taking is most important. And for that, you can use the So Stoned acronym developed by colleagues from us from Antwerp. And that helps you remembering all the important aspects, like since when do you have these symptoms? Occurrence, how often do they occur? What type of symptoms? Is it vertigo, dizziness, etc.? What type of triggers? Is it sudden, like in Meniere's disease, or is it with head movements, like BPPV? You have to ask, of course, for the otological symptoms, especially for Meniere's disease, like hearing, tinnitus, or pressure. You have to ask for neurological symptoms with a very strong focus also on migraine, because migraine and Meniere's disease might look like each other. You have to ask about the evolution, so how did it evolve, and how long do these attacks last, because they should at least last for 20 minutes. But you see there, the occurrence and the triggers, I made them blue, because those are the most reliable ones. So if patients say, oh, I feel vertigo, or I feel, it's shaking a little bit, the type of symptom is not very reliable. But the trigger, so what does it luxate? Is it spontaneous or not? And how often? Those factors are very reliable in history taking. So you should focus on them. And sometimes the triggers are very easy. So here you see one of our patients when he was walking in a supermarket and all of a sudden he gets a drop attack. Well, you cannot miss that this trigger is sudden. And that's also what happens with Meniere's disease. The attacks are quite sudden. Patients might tell you, oh, I feel that the attack is coming, and then all of a sudden it's there, but we still call it sudden. They cannot really luxate it with head movements or something like that. But as I said, patients with Meniere's disease might also develop other vestibular disorders. And if you look here at a nice article we made, you see that there is often overlap between different vestibular disorders. If you look at Meniere's disease, for instance, and vestibular migraine, there's quite an overlap. But also with vestibular function loss like bilateral vestibulopathy and Meniere's disease, or BPPV and Meniere's disease. So it means that patients with Meniere's disease can not only suffer from the attacks of Meniere's disease, but also from the fact that the vestibular function is not working properly, or that there is some migraine, or what they can also develop is functional problems. So what we call psychosomatic problems. And then patients might really have a lot of symptoms, and you need to explicitly screen for it. So if you ask a Meniere's disease patient only about the attacks, you're not asking properly enough. You should explicitly screen for functional problems and the fact if that their vestibular function is not working properly or not. Because you should also treat that with hypofunction, rehab, with functional problems, psychotherapy or medication. So what do we have on the diagnostics? So if you want to diagnose Meniere's disease properly, of course, you have the criteria as I showed you before. And a very common mistake is that people say, okay, it cannot be Meniere's disease because the VNG doesn't show any results, which are abnormal. But that's not true. The vestibular exam, in which I mean the VNG or head impulse test or something like that, they are not in the criteria. The only thing what you need to have is to have an objectified hearing loss. So like here, in this patient, for instance, we measured this patient in 2018, 2026. And again, you see in 2018, there was quite a big hearing loss on the right. And in 2026, we saw it was better. Of course, normally, it doesn't take 8 years to see these fluctuations. But here it was just very coincidentally that we only measured the patient 8 years later. But this fluctuating hearing loss or already the presence of a hearing loss in the low to medium frequencies, that shows that there is Meniere's disease. But especially in the beginning, patients might not have a persisting hearing loss. Because as I said before, because of that fluctuating function, patients have bad hearing. And when they come to you, hearing recovered again. And so in the beginning, it might be quite tricky to really detect that hearing loss. If the patients already have it for years, then it's more often easy because then the hearing loss remains. So what you can do if you want to be more specific is that you ask patients, for instance, to record the hearing during an attack. And now with the smartphones, that can really help. So we just ask patients to record the hearing when they're at home and they don't have an attack. And then preferably we say, okay, maybe it's best if you record your hearing in a quiet room if possible. And if you have an attack, and you might have the attack in the same environment, please check your hearing again in the same room. So you must have a baseline and preferably test during an attack in the same environment and compare it to baseline. A hearing test at home is not perfectly reliable when it comes to the absolute thresholds, because you might not absolutely hear, let's say, whether it's 5 or 10 decibels hearing loss. But what you can see is that there is a difference. So here in this patient, for instance, when there was no attack, there was a little bit hearing loss on the right. But during an attack, we asked the patient to record it at home, and then you saw a very clear hearing loss during the attack. So that can really help you in making the diagnosis, especially if the patient, just like many people nowadays, has a smartphone to detect it. And there are some nice apps out there that can help you with it. Of course, capturing nystagmus is not really something that is in the criteria. But if you are sometimes in doubt, is this really a vestibular problem like Meniere's disease or something else, and you still cannot objectify the hearing loss, then it can help you to ask the patient also to record the eye movements during an attack. Like here, this patient, we just asked them to make a nice movie of the eyes during an attack. And seeing the nystagmus shows already that at least we are looking at a vestibular problem and not something else like a panic attack. And that really helps you in already confirming your diagnosis more. So nowadays, with a smartphone, you can also use some adapters, which are very nice. So in our clinic, we use this type of adapter. It's very easy. It's 3D printed, not very expensive. And this can help you to record the eye movements very nicely. Like here, this patient with the Meniere's disease attack, what you see is if she focuses on her eyes, you get a very clear view of the eyes and you can nicely see the nystagmus. So what you can do is that you can really capture the moment. And capturing the moment can tell you, okay, a nystagmus means at least a vestibular problem. And what you can do even is ask the patients to look in all three directions. So you can see, for instance, is the nystagmus always going into the same direction, like here to the right, or is there maybe any direction changing nystagmus? That's something you don't want to see, for instance. So again, for the diagnosis, what you really need is the criteria, proper history taking, and try to record hearing loss. And if that's all very challenging, try patients to capture the hearing loss at home using the smartphone. And if you're even in doubt whether it's vestibular or not, just ask them to film their eyes during an attack. But then they need to film it when the symptoms are the most severe, because then you're most likely to see the most severe nystagmus. So once you have made the diagnosis and you checked, is it Meniere's disease or maybe Meniere's disease with something else like hypofunction or functional/psychosomatic symptoms, then you need to treat them all. But for here, I will first focus on the treatment on Meniere's disease. And this is already a very interesting thing. Because what is a good treatment? And of course, many people say, okay, this, and this is the treatment for Meniere's disease. But it's not as simple, because as I said before, Meniere's disease is actually a heterogeneous disorder, which means that many disorders lead to Meniere's disease. So it might be that not all patients need the same type of help or treatment. And also again, that targeting eye drops might not be the way to go. Furthermore, Meniere's disease is a self-limiting disease. So what you see is that people have peaks in which they have a lot of symptoms, a lot of attacks, and then afterwards it stops again. So if you want to do research and find out what is the best treatment, well, that's challenging because after 2 years, most patients will already feel better. So if you do an intervention and you evaluate them after 1 or 2 years, they will already say, okay, I feel better. But they would also have felt better if you would have done nothing. So here you see a graph. Don't look at the graph because it's too complicated. It's just to show you a study where they did different types of analysis. And this was a study where patients came on a waiting list because they had such disabling symptoms that they said, I want to have surgery now. Please give me surgery. But because of the COVID that happened and also administrative issues, this study where patients said, I want to have for this study the surgery, they were put on a wait list. And that wait list was on average 1.2 years. And what happened after 1.2 years, that 80% of the patients eventually refused the surgery. Because if you just waited for 1.2 years, most of the patients say, oh, I feel better, I don't need the surgery anymore. So even in what we call intractable Meniere's disease, which means that there were patients who had attacks and said nothing helps, please do surgery. If you just wait, 80% will feel good enough and they don't need any surgery. So that's good to understand in this case, that if you do nothing, actually also Meniere's disease will eventually subside. But that doesn't mean that you need to treat them in between. And that we will discuss now, because for attacks, you want to help patients, of course, especially to feel better during attacks, but also to recover quickly after attacks. So if you look at the step-by-step plan for Meniere's disease, from a more evidence-based point of view, you have your diagnosis, you can give medicine, you can give intratympanic injections with corticosteroids or gentamicin, you can perform a neurectomy or a labyrinthectomy. So let's first take a look at the medicine. Well, think again, Meniere's disease, you have an attack. And during an attack, your vestibular function fails. So it means you get an acute vestibulopathy. If you here see in a mice in which the vestibular function was ablated, so it was shut down, you see this rat feels very bad. It has severe vertigo, unsteadiness, and doesn't know what's up or down. And that's exactly what happens during an attack. But if you have an attack and your vestibular function might not recover perfectly, you need to compensate. So it means that your brain needs to compensate. And in order to compensate, so to improve quicker after an attack, you can use medication. So one of the things what was already found out very long time ago is that if you give a placebo after destruction of the vestibular system in cats, they recover in 7 weeks. If you give beta-histine, they recover in 3 weeks. So it means that beta-histine improves the recovery after you lose your vestibular function. More importantly, what you should not do is suppress the vestibular function. Because if your vestibular organ fails, whether it's an acute vestibulopathy or a Meniere's disease attack in which your vestibular function does not recover, you should not suppress the vestibular system. Because if you suppress the vestibular system, for instance with cinnarizine, then the brain cannot work properly and then the patients will feel very bad. So although suppression in the beginning of an attack, let's say maybe for a couple of hours or 1 day is okay, you should never give it longer. Because if you look at it after an acute loss, so a neuritis or neurectomy, you see that cinnarizine really reduces and impairs central compensation. Placebo, you just get recovery in 3 months, just like with acetylleucine, but with beta-histine, you recover in 1 month. And I especially want to highlight a little bit the difference in these two, because after an attack, you still need to recover. And for that, you can use some medication. So the take-home message is, if you lose your vestibular organ in general, whether it's a neuritis or a neurectomy, or whether you have a Meniere's disease attack in which your vestibular function is lost and it doesn't recover fully, you should not suppress the vestibular system after the attack. That's the first one. So don't use cinnarizine for a very long period of time. But if we look more at the evidence that's there for instance, acetylleucine, we see also from a very nice systematic review, there is no solid evidence of the efficacy of acetylleucine in vertigo or dizziness at all. So not only Meniere's disease. So what is the evidence we have to use beta-histine to improve this compensation? So again, if we now look at beta-histine after a neurectomy, you see it 2 plots, and you see the body sway area and the subjective visual vertigo. What you mainly need to know is that the lower the values, the better the compensation. And what you see is, if you look in the days, that if you compare placebo to beta-histine, that beta-histine has significantly lower values than placebo, which means that you increase the speed of compensation with beta-histine. Eventually, you will end up the same, but with beta-histine, you improve it, so it goes quicker. So therefore, you really need to treat the patients, at least that's what we do, with beta-histine for 2 to 3 months after you lose your vestibular function. So if you have a patient with Meniere's disease that has several attacks and it wants to compensate quicker, then it might be that you need to use the beta-histine a little bit longer if you want to improve the compensation. And we'll go more into that now. For instance, here you see again nicely videos of the rats after a hemilabyrinthectomy. You see the control group is still looking after a while on day 8 for what's up, down, still vertiginous, still very dizzy. But if you see the rat that's using beta-histine, it's actually much more active. So if we now specifically focus a little bit more on Meniere's disease, patients with Meniere's disease and a vestibular loss, also the evidence shows exactly the same. The head tilt and the body sway. And if you compare placebo to beta-histine, you see that beta-histine in the beginning significantly improves the parameters of compensation, because the lower the values, the better. And that's interesting that especially you gain in time. So in the end, beta-histine is almost equal to placebo, but the effect of beta-histine is that it increases the speed of compensation, and that's why we give it. So if you have a vestibular loss, whether it's because of a neuritis or a neurectomy or Meniere's disease attacks, the best is, of course, to get people moving, give them exercises with beta-histine, but don't suppress the vestibular system, because that's not something you want. So what can we do? Yeah, we can give intratympanic injections like corticosteroids, and that has been shown so far to be effective. Well, you can give corticosteroids and gentamicin, where corticosteroids aim at not destroying the labyrinth. Gentamicin aims to destroy the labyrinth. So that's something we would not advise in the beginning. Corticosteroids you might also repeat. You can even repeat if you want every 8 weeks. But if the effects do not work anymore, then you should go for gentamicin. The effect we always evaluate after 8 weeks, because it takes a while before gentamicin and corticosteroids might work. So if we focus a little bit on the gentamicin first, we see that gentamicin is quite tricky for the vestibular system, but not for the cochlea. So what you see is here the dose, and the dose in a low dose, gentamicin is not bad for the vestibular organ and not bad for hearing. But if you increase the dose, what then happens is that it becomes bad for the vestibular system, but it's still safe for hearing. And therefore, we aim to give gentamicin at a dose which is bad for the vestibular system, but not for the hearing. And in general, that's 30 milligrams per milliliter. So 30 milligrams per milliliter. Well, if that doesn't work, you can always go for a neurectomy. But a neurectomy we should only do if patients are really sick and nothing helps. So if patients start sending you videos that they feel very bad, then of course we would say, okay, do a neurectomy. The nice thing of a neurectomy is that you can perform it in patients who still have functional hearing. Because if a patient has functional hearing and vertigo attacks, with a neurectomy you can destroy the vestibular part of the nerve, but you can keep the hearing part intact. So a neurectomy is only for patients who still have good hearing, at least sufficient hearing, functional hearing, but have therapy-resistant Meniere's disease. So during a neurectomy, what you do is that actually you try to cut the nerve. So what you first do is that you look here in the ear. This is a retrosigmoidal approach. And what you do is that you visualize the nerve. And then if you visualize the nerve, you can cut it. And often it's around there, these little vessels that you see there. It separates the hearing part from the vestibular part. So if you try to separate the nerve there, you know that you cut the vestibular part and not really the hearing part. And which is good, because I will not go too much into detail in the surgeries, but if you're successful, you see that the head impulse test in this case shows that it was an effective treatment, because we do the head impulse test and the head impulse test shows that the vestibular function is not working properly anymore. Well, hearing preservation results for neurectomy are very good. Vertigo control also very good, but of course you get a persistent loss of vestibular function. So, but what if a patient doesn't respond to a neurectomy, which is fortunately almost never the case, but what if they have no sufficient hearing, if they're already deaf and have attacks that don't respond to anything, even not corticosteroids or gentamicin? Then you can go for a labyrinthectomy. And a labyrinthectomy is that you just destroy the whole vestibular system. So here you see a right ear with the horizontal canal, the superior canal, and the posterior canal. And what you do eventually is that you just drill the canals open until everything is open, and then your hearing and balance are gone. Here I'll just show you how you drill the canals open, but eventually you destroy everything. This is very, very, very effective. And as you can see also after the attack, you see that there is some nystagmus showing that the vestibular organ was really ablated. Then also other surgical options were mentioned in the past, or other non-surgical options like a pressure device called the Ménière or prism goggles or endolymphatic sac surgery. They all didn't show any effect. Now people came with endolymphatic duct blockage. Here you see a right ear where people said, okay, if you take the endolymphatic duct, which you can see here, it's a very tiny duct, and if you clip it, it might help improve Ménière's disease. Well, we did it. Actually, colleagues of us did it mainly in the Netherlands. We just participated in the trial, and putting these clips on the endolymphatic duct actually didn't show any difference comparable to placebo. And this will hopefully be published very soon. So this shows this type of surgery doesn't work. Now in China, people are also thinking about triple canal plugging. So this seems to be the new hot topic, in which you just harvest some fascia, or you can even use bone wax. And what you do is that eventually in this right ear, you open the canals very carefully, and every canal is blocked and in that way plugged. And one of the ideas is that when you open the canal like here, and you put a little plug in it, and then in all three of the canals you do it, that eventually maybe the Ménière's disease might disappear. But to be honest, currently the results are not perfect yet, and we are really curious whether this is really a treatment. But it's just for you to know. Well, and what you can see is that if you do it carefully, you can even preserve hearing, because this is a patient of us after triple canal plugging. The green one is the newest test, the orange one was before the surgery, and you see that actually the hearing can be preserved. But in general, counsel the patients for some hearing loss. So triple canal plugging is not perfect. So to end up, as we said before, many patients with Ménière's disease might also develop other problems, like vestibular hypofunction, but especially if it's chronic triple PD, which is a functional problem, or psychosomatic. And then don't only treat the attacks, also treat the comorbidities. Here, look at this patient who developed, in addition to his vestibular disorder, a functional disorder, a psychosomatic disorder. So what you see is that he's continuously swaying and he needs to hold his head in order to sit still. This is not a vestibular problem. Also, if you ask him to walk, for instance, it seems to be very unstable. But these are signs of a functional disorder. So if you treat this patient only for his vestibular disorder, he will not be happy. You should also treat him for his psychosomatic problem, or what we nowadays call functional problem. And then you see, if you do it like that, he's actually able to walk quite okay again. So therefore, the main message is, if you treat Ménière's disease, also screen for other symptoms and other disorders, and if they have it, treat it in parallel with Ménière's disease. So to conclude, the approach to Ménière's disease, step 1, make a nice diagnosis, screen for comorbidities, including hypofunction or functional problems like triple PD, persistent postural perceptual dizziness. Then, if you cannot objectify hearing loss in the beginning, try to use new diagnostics like having patients using their smartphone to record the hearing loss at home. And once you have found it, and you have diagnosed Ménière's disease, use only an evidence-based treatment. Because now with these new insights, we need to rethink the workflow we had in the past that mainly targeted the eye drops. So, thank you very much for your attention, and if you have any questions, please let me know.